Okay, let's dive right into this explainer. Today, we're setting off on a really vital clinical diagnostic journey into the pharmacological management of coughs. Whether you're prepping for your nursing exams or you're already out there on the floor treating patients, mastering this topic is absolutely crucial. We aren't just looking at random drugs today. We're figuring out how to match the right pharmacological tool to the right clinical presentation to provide safe and effective patient care.
Here's our roadmap for today. We're going to cover understanding the cough reflex, classifying the cough, antitussives for dry coughs, expectorants for excretion, mucolytics for thick mucus, and finally, clinical scenarios and duties. Let's get right to it. Section 1. Understanding the cough reflex. Before we even think about pharmacology and medication administration, we really need to understand the physical and emotional distress of the symptom itself. Just imagine a patient who's been coughing continuously for days on end. It's ruining their sleep, causing profound chest discomfort, and literally derailing their daily life. It is just exhausting. Grounding our medical data in human empathy is absolutely critical here. As a nurse, seeing this stressful presentation sets up a vital need. You have to understand exactly why this cough is happening before you even consider reaching for a med.
Now, what's really fascinating about this is that a cough is not just a nuisance. It can actually expel air at speeds up to 50 miles per hour. That's incredible, right? It's a highly powerful protective reflex. In fact, it's one of the body's most vital defense mechanisms. Its entire job is to help clear the respiratory tract of secretions, foreign particles, and irritants. So when we treat a cough, we're actually interfering with a primary bodily defense, which is exactly why we have to do it so carefully. A cough doesn't just happen in a vacuum. It can be triggered by a whole bunch of things: upper respiratory tract infections, pneumonia, tuberculosis, asthma, or COPD. It could also be lifestyle or environment related, like smoking, allergies, or environmental irritants. It can even stem from the GI tract, like with GERD. To treat the symptom effectively, you've got to constantly be thinking about these underlying causes. We're treating the whole patient, not just silencing a symptom.
Section 2. Classifying the cough.
This right here is your absolute most crucial clinical decision point. There are two major types of cough. First, the productive cough, often called a wet cough, which produces sputum or mucus. And second, the non-productive or dry cough, which happens without any sputum production at all. Whether a cough is wet or dry dictates absolutely every single pharmacological choice we make next. You simply cannot choose a medication without making this distinction first.
Section 3. Antitussives for dry coughs.
Now we're opening up our pharmacological toolbox. Let's look at the first of our three major tools, specifically tailored for a non-productive presentation: antitussives. These are drugs that suppress the cough reflex. They're used mainly for those dry, irritating, non-productive coughs that just keep patients up all night. The mechanism of action is pretty fascinating. Most of these drugs go straight to the brain. They act directly on the cough center in the medulla to reduce the frequency and intensity of the coughing. They are literally telling the brain to stop triggering the reflex. Let's walk through these specific examples you're going to see in practice. We've got codeine, dextromethorphan, and full codeine. But, acting on the central nervous system comes with some baggage. You absolutely must monitor for adverse effects like drowsiness, dizziness, constipation, and nausea. Most importantly, you need to watch out for the severe risk of respiratory depression, particularly when you're using opioid agents like codeine. So, the absolutely crucial point is this: never ever use antitussives for a productive cough. Think about it. If the lungs are full of mucus and you give a drug that tells the brain to stop coughing, what happens? The mucus just stays stuck in the lungs. Suppressing a wet cough leads to the dangerous retention of secretions, which can quickly lead to severe infections like pneumonia. This is a massive clinical error you have got to avoid.
Section 4. Expectorants for excretion.
All right, so we've talked about stopping a dry cough. Now let's introduce our second tool, meant for when the patient does have mucus that desperately needs to move. Expectorants are a completely different ballgame from antitussives. We aren't stopping the cough here. Instead, expectorants promote the hydration of respiratory secretions. By drawing water in, they increase the volume of the secretions and make the sputum less viscous, meaning less sticky and thick. It's kind of like adding water to a dried out slip and slide. It just gets things moving. The goal is to make the mucus easier to expel, making the patient's cough highly successful. The classic example you'll see everywhere is guaifenesin. Now, while it's fantastic for helping clear the airway, you do need to keep an eye on some specific adverse effects. Because of how it works in the gut and body, it can trigger nausea, vomiting, and general gastrointestinal discomfort.
As a nurse, you're going to need to monitor your patient's GI status while they're taking this.
Section 5. Mucolytics for thick mucus. We've reached the third and final drug class in our rule of 3. This is your heavy hitter for severe respiratory congestion. Mucolytics break down thick mucus and reduce its viscosity. And this brilliantly illustrates the power of pharmacology. These drugs don't just add water like expectorants do. They actually chemically disrupt the structure of the mucus itself. They break it down at a molecular level, making it vastly thinner and therefore so much easier to cough out of the respiratory tract. Your prime examples here are acetylcysteine, bromhexine, and ambroxol. Because of their heavy-duty mechanism of action, their clinical uses are tied to chronic, serious respiratory diseases. You're going to use these in patients suffering from chronic bronchitis, COPD, cystic fibrosis, or really any condition characterized by incredibly thick, stubborn respiratory secretions that the body simply cannot clear on its own. But as always, with strong drugs come significant adverse effects. While nausea and throat irritation are pretty common, the primary red flag you really need to watch for is bronchospasm. Because you're introducing a chemical agent into compromised airways, it can cause the airway to spasm and tighten, which is a critical respiratory event. Section 6. Clinical scenarios and duties. Let's move on and see how all this builds into your golden rulebook for exams and clinical life. If it's a dry cough, you use an antitussive. If it's a productive cough, you use an expectorant or a mucolytic. And crucially, if it's a productive cough, you never ever suppress it unless specifically directed by a highly specialized medical order. Keep this framework locked in your mind for sure. Your responsibilities extend far beyond just handing out pills. You have to assess the nature of the cough first. You are the one determining if it's productive or non-productive. You have to monitor the characteristics of the sputum. Crucially, don't forget the non-pharmacological steps here, like encouraging adequate fluid intake. Fluids naturally help thin secretions. You also need to educate your patients on correct medication use and closely monitor for all those adverse reactions we just covered. Okay, let's test this out with a quick clinical scenario. A patient presents to you with thick, tenacious sputum that they are finding incredibly difficult to expectorate. Based on the framework we just built, which medication class is most appropriate here? Think about it for a second. If you said mucolytic, you are absolutely correct. Because the sputum is so thick and tenacious, we need a drug that chemically reduces mucus viscosity to facilitate airway clearance. An expectorant might help a little, but a mucolytic is the absolute most appropriate heavy hitter for this specific stubborn presentation. Excellent diagnostic logic. I'll leave you with this final provocative thought. If we successfully treat the cough, if we quiet the dry hack or clear the thick mucus, are we remembering to identify the underlying cause? Managing the symptom is really only half the battle. Successful treatment ultimately depends on finding out why the body triggered its defense mechanism in the first place. That is the true goal of safe, effective, holistic patient care. Thanks for joining me on this explainer, and keep thinking critically.